Hello everyone, welcome back to a Specialty Optometry channel. So today we will be discussing an important topic in ophthalmology, that is keratoconus management algorithm. So, so what is the keratoconus? So the keratoconus is basically a progressive eye condition that affects the cornea and that will lead to the visual impairment. So a proper management is a key to maintaining the vision and improving the quality of it. So there are different management modalities available for managing the keratoconus, and the main aim of management of keratoconus is to provide the visual rehabilitation in a safe and effective manner with the different optical mechanisms, and also to stop its progression if there is any. So the management of the keratoconus basically depends on the visual need of the individual patient, and these may vary as disease progresses or if the problem arises with a particular approach. It also depends on the state of progression. So always remember, tailor to the individual patient. So there is no thumb of rule of management of keratoconus. Every patient present to you is a unique with a diagnosis of keratoconus has to be managed individually. So now coming to the keratoconus management algorithm. So when a patient come to your clinic and you have diagnosed the keratoconus, the first and the most important thing is to take care of these three factors. To treat any ocular allergies aggressively and emphasize the importance of avoiding the eye rubbing to prevent the disease progression. Clearly explain the nature of disease and outline what the patient can expect from the treatment plan. It's very important to consult the patient and the patient parents about the importance of eye rubbing and their treatment plan depending on their disease condition. So, during the initial visit, after assessing the patient vision, conduct a contact lenses trial to evaluate their vision potential if their vision isn't improving the glasses. And in the follow-up visit, it is important to assess whether the disease is progressive or non-progressive. If it is non-progressive disease, then there can be a two scenario. In certain special scenario, such as in younger patient less than 15 years of age, or patient who has a history of hydrops in the other eye associated severe corneal keratoconjunctivitis, or if the patient is unable to follow up on a regularly, then you should not wait for the disease to progress. In such cases, the collagen cross-linking can be planned during that visit itself. If the patient is older and has no other risk factor, assess their best corrected visual acuity, and if the vision is satisfactory, advise them to use the contact lenses or a spectacle and continue the regular follow-up until they reaches 20 to 30 years of age. If the patient vision is unsatisfactory with the contact lenses or they have a poor tolerance to the contact lenses, evaluate whether they could benefit from the intrastomal corneal ring segment, and if not, remaining options are either deep anterior lamellar keratoplasty or penetrating keratoplasty. When the disease is progressive, it is important to determine whether the CXL is possible or not. If the CXL if the CXL is possible, then we have three options: either collagen cross-linking alone. In this scenario, assess the epithelial of EP of, or that is epithelial of corneal thickness. If the corneal thickness is more than 400 microns, proceed with the standard Dresden protocol or an accelerated protocol with at least 10 minutes of UV radiation. And if the epithelial of corneal thickness is less than 400 micron, then the most effective protocol involves using a hypoosmolar dye or hypoosmolar dye prepared with HPMC instead of dextran. There are other combining methods also which can be considered, the CXL with either PRK or ICRS in a selective cases. These approaches can help to regularize the uh, corneal topography and improve the vision quality. And there are other options. ICL can be also considered for a patient with a more or less regular astigmatism at least 1 year after CXL. If the CXL is not possible or the patient has previously history of field hydrops, Assess whether the vision is satisfactory with the contact lenses or not. If the visual acuity is good with the contact lenses, you can either plan for Bowman's layer transplant or continue to observe the patient with the regular contact lenses use. And if the vision does not improve even with the contact lenses, then only the remaining option is keratoplasty. And if the hydrops scar is in the center or large, then plan for PK. And if it is a small or paracentral, you can plan for DALK by using layer by layer dissection. And if there has been no previous hydrops, you can plan for DALK also. So remember, in keratoconus, the study has been shown that the long-term outcomes of penetrating keratoplasty are also excellent with a low failure. So in all scenario, never ever forget to ask your patient or the patient parents to control the eye allergy and avoid the eye rubbing and counsel about the expected outcomes. So point to written. So treating eye allergy and counseling to the patient and their parents is the most important, and the management related to keratoconus all depends on the patient age, progression, and the patient expectation. And always remember that the CXL can halt the disease. However, the contact lenses is a key for maintaining quality of vision. Thank you.